Welcome to the show, Dr. Joyce O'Shaughnessy. How are you doing tonight?
Hi, April. How are you? Hi, everybody. Good evening. Good to be back again this year. Awesome that you do this year after year. It's so good and glad to be here.
Well, thank you so much for making it possible to have you, because I know you're so busy. You're coming off of another show that you were just on earlier this evening, so you're a busy lady. So I really appreciate you always making time for this show
Always,
and
always.
helping us. So I'm
Mhm.
going to flip over here to some of the questions that we have. I have a lot. So those of you watching and seeing my face turn to the side, that is because I am going over to our questions. While I'm looking that up, Dr. O, I would love it if you wouldn't mind starting off, like a lot of times we do, with just kind of the latest news from the triple negative breast cancer front.
So let's see. Triple negative breast cancer is associated with having not always, but a higher risk of triple negative if breast cancer runs in the family and if genetic testing is done and you have a BRCA1 gene or a PALB2 gene or a BRIP1 gene or RAD51C or D. So there's a whole bunch of genes that can run in the family that are associated with triple negative breast cancer. So hereditary breast cancer is enriched for triple negative. It can be ER positive, estrogen receptor positive too, but it's enriched. So that's just one thing to bear in mind. When in doubt, go get genetic testing because it's become very inexpensive. For example, there's a company called Invitae that it's only cost about $200, and it's a really comprehensive evaluation of all the genes that are known to increase the risk for breast cancer and ovarian cancer. So when in doubt, just get tested, and your regular doctor can order that for you, the Invitae test. So that's the first thing. The second thing is,
could I ask you real quick?
yeah,
I just was wondering. We were talking about this earlier. How many different genes are they testing for now with breast cancer?
Yeah, and each of the tests is a little bit different. And as long as they're doing like the top 25, some of the tests go up to 100 genes, April, but that's probably excessive. Myriad MyRisk, for example, does 25, and that's enough. Ambry Breast Next does 25, 30, as I recall, but they're going up. Every year the numbers go up because this is still a discovery effort. And that's another important point. If you've got a family history of breast cancer or a personal history of breast cancer and you've had genetic testing, but it was before 2016, 2017, they used to only test for BRCA1 and 2 and maybe a few others, but now we're much more comprehensive. So I really encourage everybody to go back and get it done again. If you've got a family history, personal history, particularly under the age of 50, but for triple negative, you were diagnosed with triple negative at any age, regardless of family history, genetic testing should be covered by insurance. So it's just getting more and more liberal what insurance is going to pay for. But like I said, even out of pocket, if insurance says they're not paying, you can get a really good test for like $200, $250. So really important. Secondly, I would say that if you've got really dense breasts, and the Texas law has now gone nationwide that women have to be told if they got dense breasts on mammogram, really dense breasts, they need to be told that. And if you have a family history of breast cancer, you got dense breasts, you really want to be thinking about an MRI. That's really important because you got to pick it up early. You got to pick up triple negative early because it's fast growing. And if it's not caught till later because the breasts are very dense, it can get big, before anybody finds it. So that's another point. Not everybody who's got dense breasts, however, needs to go get an MRI, not at all. But if you've got a family history or a personal history, or you've had biopsies that showed any precancer or what have you, if you've got dense breasts, because the 3D mammograms now are really the standard, they're way better. The old mammograms, the 3D can really look through dense breast tissue, but still the 3D mams will say, hey, heterogeneously dense breast tissue. You know what? If you got breast cancer in your family, it's time for an MRI. Okay, so that's important as well. And then we're into treatment for TNBC. Really, it doesn't really matter whether you have a lumpectomy, radiation, or mastectomy. Now, if you've got a strong family history of breast cancer, you're going to want to have a bilateral. That's a double mastectomy. But if you don't have a strong family history, there's actually not a survival advantage to having a mastectomy over a lumpectomy radiation. So that's not what cures triple negative, is what you do with the breast. What cures triple negative, unfortunately, is chemotherapy if you're stage 1, which means nodes negative and small cancer under 2 centimeters, or if you're stage 2, 3, larger cancers with or without positive lymph nodes, the addition of immunotherapy. Pembrolizumab is the generic name, and Keytruda is the brand name. And so this is a big advance in triple negative breast cancer over the last 2 years, is the addition of the immune therapy preoperatively, Keytruda, to chemotherapy preoperatively in stage 2 and 3 triple negative breast cancer. That's made a very nice improvement in the cure rate, the chances of staying cancer free. The follow-up's only 4 years, but that's still pretty good with triple negative breast cancer, because unfortunately triple negative tends to recur quickly. If it's not cured, unfortunately, it can come back within 2, 3, 4, 5 years. So 4 years is good. So that's really, really important, that the standard of care is preoperative chemo with the Keytruda. The Keytruda continues for a year. So that's a big advance, April. The other thing is if women have metastatic triple negative breast cancer, there about half of the women will have, the cancer will have a protein called the PDL1. And if they have the PDL1 protein on the metastasized triple negative breast cancer, then they can get Keytruda as the first treatment for metastatic disease. Another advance that's very important really pertains only to women who have a BRCA1 or a BRCA2 mutation. And there's a pill, the generic is olaparib, and the trade name is Lynparza. It's a PARP inhibitor. And for women who get, for example, with triple negative, they get preoperative chemo with or without the Keytruda. If there's any cancer left, so in spite of the preoperative therapy, they go to surgery, there's any cancer left in the breast or lymph nodes under the arm, they're not complete, it's not completely gone. Then if they've got a BRCA mutation, BRCA1 or 2, then after surgery, after radiation, if they need radiation, then it's now standard to take 1 year of the Lynparza pill. That's made a big improvement in, again, the cure rate. So we've had some good advances over the last couple of years that really are now standard of care. There's a lot more to say. I'm going to stop talking though, but there's a lot more to say about what's coming, Rachel, April, but that's the advances so far in the last couple of years.
So crazy. So much has changed. It changes quickly, but then it's also slow. You know what I'm saying? It's like
it's incremental. It's
yeah,
incremental.
yeah.
There's still, unfortunately, a fair number of ladies we're not curing yet. So yeah, every advance matters, but we're still not there.
Right. So I think I heard you say that there was one instance where you would recommend a double mastectomy. Could you describe that instance again and why the double mastectomy would be of benefit?
Yes. So if a woman has a BRCA1 mutation, she's inherited a BRCA1 mutation, for example, or PALB2 mutation, her risk of getting, or BRCA2 mutation, her risk of getting a second breast cancer in the other breast is really quite high. So, or if a woman comes from a family where there's a lot of breast cancer and or ovary cancer, even if she's genetically tested and you can't find a gene in the family, nonetheless, there's a strong family history, that's the time to get the bilateral double mastectomy, because, there's a genetic predisposition there. And when that's there, the risk of getting another breast cancer, when you've had the first breast cancer be triple negative, is really quite high. That's different, April, for women, for example, of estrogen receptor positive breast cancer. Even if they have a strong family history or they've got a BRCA2 mutation, BRCA2 tends to be ER positive breast cancer, those women get very, very effective anti-estrogen therapy. We turn off the ovaries. If they're premenopausal, turning off the ovaries with the shots the Lupron or the Zoladex shots, and then they're taking pills, whether they be tamoxifen or one of the aromatase inhibitors. Those anti-estrogen therapies not only dramatically increase the cure rate of estrogen receptor positive breast cancer, it reduces dramatically the chances of getting a new breast cancer, a second breast cancer. So it's preventative. We don't have that in triple negative breast cancer. There is no preventative. So if women have a strong family history, or they're known to have a mutation, an inherited mutation, that's the time to get a double mastectomy.
Gotcha.
If you, for example, if a woman gets an MRI and there's something in the other breast, it's biopsied and it's like a precancer, that's probably another reason to get a bilateral mastectomy. And then the last reason is simply the woman wants it. She doesn't want to worry about this anymore. She doesn't want to go in for mammograms and MRIs and have a possibility of a biopsy. She just wants it. That is a perfectly reasonable reason.
Yeah, and I think the big takeaway from everything that you just described is that the bilateral mastectomy is to actually prevent a second breast cancer. It's not to prevent recurrence.
Right. That's very.
I caught that. I'm not as dumb as I look after all.
That's right. It doesn't influence recurrence of this breast cancer and how you're going to do from this breast cancer. It has to do with down the road getting a second breast cancer. You're spot on. Yep.
Gotcha. Okay. I'm going to hit some of these questions real quick. We're going to go through as many as we can in the time we have here. So Paisley, who was on the show earlier, she wanted to know, what is the milestone for triple negative breast cancer? She's asking if it's 3 or 5. I know back when I had it, you told me 8 was the one. I'm curious if it's changed.
Well, 8 is my time to say to somebody, you are as close to 100% cured as anybody ever is in this world, and you don't need to see me anymore. So I kind of declare victory, 100% victory at 8 years. But so what I tell women, April, is that by 3 years with triple negative breast cancer, by 3 years, if they're still cancer free, they have outlived 95% of their risk. So let's say, for example, a woman got preoperative chemo and Keytruda. She still had a positive lymph node left. Okay. So it wasn't completely gone. It was still a positive node. So she has risk for that cancer coming back. Okay. Now she's going to get more Keytruda. She's going to get radiation. She's going to get either Lynparza if she's got BRCA1, or she's going to get, capecitabine, Zolota chemo pill if she's doesn't have an inherited mutation. So she's going to have her cure rate increased by other things after surgery. But still, let's say she's going to have 20% risk of cancer recurrence, in spite of the fact that she's at everything that we know how to do. Still 20% risk. Okay. How does that risk play out, April? Okay. So 50% of that risk is gone. 50-60% of that risk is gone by 3 years. So now she's down to just an 8 to 10% risk. And then by 5 years, about 95% of that risk is gone. So now her remaining risk is low single digits. So you can see that remaining risk, whatever it is, and it depends on how much cancer is left. It depends on what you started with, and it depends on how much is left, because we can estimate what's the remaining risk of recurrence. And 50-60% of that risk is gone by 3 years. 90-95% of that risk is gone by 5 years. And I say pretty darn close to 100% of that risk is gone by 8 years.
That's a really good answer. I like hearing that 95% after 3 years based on certain circumstances like you described there. That's a positive thing for folks to look forward to, because you always look for those milestones and those are big wins, I'm going to skip around some of these questions to make sure that I cover a little bit of questions from a lot of people rather than a lot from one person. So I'm going to skip to a question from Kim. She says, for TNBC patients with stage 1, what are the chances of recurrence?
They're low. For stage 1, which is under 2 centimeters and node negative, we're probably up around, like if we take 1.5 to 2 centimeters, the risk without any therapy of the cancer recurrence, if patient got no chemo at all, is going to be in the 25, maybe 30% range. And with our good chemotherapy, it's more than 90%. Cure rate, it's 95%.
That's awesome. I think Kim's going to be really excited to hear that. That's awesome. Courtney asks, as a BRCA1 breast cancer survivor, at what stage should someone's child be before having genetic testing? I know she has a little girl who's probably 12 or something like that. She's curious about this.
It's age 25, or if a woman herself, the mother, was diagnosed young herself, let's say she was 30, we tend to want to do genetic testing 10 years younger than the youngest woman who was diagnosed with breast cancer. So if mom had breast cancer at 30, rather than wait till 20, and she's got a BRCA1, rather than wait till 25 for her daughter to be tested, maybe her daughter could be tested at 20. So 25 is the general rule of thumb, but there's unusual circumstances where people are diagnosed with, triple negative breast cancer with a BRCA mutation at 28, and then so around 18 to 20 years of age, her daughter could get tested.
That's a great answer. And it's ironically, she was diagnosed at 35. So it would be 25 for her daughter in that answer too. The next question is going to be from Mandy. What percentage is the likelihood of recurrence for stage 3 triple negative breast cancer if you follow the doctor's order for chemo and have a double mastectomy?
So for stage 3, it matters where you start, but it also matters where you ended up in terms of if women got preoperative chemo, with or without Keytruda, and then how much cancer was left at surgery. Is it all gone? If it's all gone, the cure rate is around 93 to 93%, I think would be a good fair estimate. If there's a little teeny bit left, just a little bit in the breast or lymph node, the cure rate's around 88 to 90%. If there's a little bit more, the cure rate only may be about 85%. If there's a lot of cancer left, the cure rate may only be 70%. So it really depends on, but if you take all stage 3 in general, and you can look at this, there's a very, very important study now in triple negative breast cancer. It's the Keynote 522, KN 522 trial. And it's been published and it's easily accessible online, et cetera. But they really do break down, the chances of recurrence in stage 2 versus stage 3 patients. And if you take stage 3 with chemotherapy without the Keytruda, I think the cure rate's probably in the 75-80% range. And then the Keytruda adds on about, 8 to a little bit more, maybe 10% improvement in the cure rate with the Keytruda.
So this is great information. A lot of the folks asking these questions are on Keytruda or have done some of the things that you've mentioned, so it'll make perfect sense to them. The next question we have here is from Paisley, who was diagnosed with stage 2 triple negative breast cancer. She says, "I'm 3 years out of treatment. I'm not being scanned or having any blood work done. Is there something that I should be having done?"
Good question, and everybody wants to know that. Like, how do I know I'm okay? And the national guidelines, we have all these best experts putting together, really going through the data, the literature, the evidence, what really helps people. Okay, and basically regular scans, absolutely not. There's no benefit to regular scans, because if you get scans and you pick up lung metastasis, unfortunately women are not going to live longer because you picked up the lung mets on scan versus picking the lung mets up, a bit later if somebody starts to cough or something. I wish that was not the case. I wish that was not a true statement, but right now it is a true statement. We don't get an impact on survival, people living longer, because we pick up the metastasized breast cancer early. Wish that weren't the case, but that's the case given our treatments in hand for metastasized breast cancer now. But I'm going to make a statement about a clinical trial going on right now that's trying to change that. But anyway, so no blood work is indicated, no scans. However, I think all of us should get full blood work with our regular doctors, not necessarily our oncologist, but our regular doctor, complete blood count, that's the bone marrow, all the complete comprehensive metabolic profile, that's chemistries, liver, bone, kidneys, once a year. And I think that's very reasonable. That's well woman care. And then if you have any symptoms, my rule of thumb is anything that lasts for 6 weeks or longer, we scan. You get a cough that won't go away, you think it's allergies, that's okay. Just go in, get a chest x-ray with your oncologist or your OB or your regular doctor, whatever, but no scans. Now, there's a test called the Signatera test that, and there's competitors as well. That's by a company called Natera. And what that is, it's a blood test looking for tumor DNA in the bloodstream, okay? What they do is they go back to the woman's original breast cancer that's over in the pathology lab. They do next generation sequencing looking for all these mutations, and they'll pick out like 16 different mutations that's personalized, individualized to that cancer. And then they look for those 16 mutations in the blood of a woman. And there's a trial going on called the ZEST trial right now, where women with triple negative breast cancer, they finished up surgery, radiation, Lynparza if they needed it, Xeloda if they needed it, then they can get their blood drawn serially, but their tumor is sequenced for those mutations to find those individualized mutations. And those mutations are looked for in the blood like every 3 months. You can come in every 3 months and get that blood test done as part of the trial. Now, if the blood now turns up tumor DNA, okay, then scans are done. Scans are done, and if there's no cancer seen on the scan, so no obvious metastasis, unfortunately, if you find tumor DNA in the bloodstream, it does mean that there's microscopic disease. You just can't find it yet on scan. And then the trial on the ZEST trial is randomizing women, flip of the coin, half get a PARP inhibitor called niraparib, and half do not get it. So what they're trying to do is they're trying to see, can we save some lives, or can we prolong survival by catching this microscopic residual disease, just microscopic metastasized breast cancer, by catching it early in the bloodstream? Can we save lives? Now, we don't have the answer to that. Now, what happened is, like last week, CMS, the Center for Medicare Services that oversees Medicare, put out a guidance document saying that for Medicare recipients, they're going to pay for, in early breast cancer, they're going to, stage 2B and stage 3. So not stage 1, but stage 2B and 3. So more advanced early breast cancer, they're going to pay for this serial monitoring in the bloodstream of this circulating tumor DNA. A lot of us have trepidations about that, because honestly, I never order it. I never order it because I don't know what to do with it. What am I supposed to do? If I find it, I get a PET scan and the PET scan's clear. What am I supposed to do with that? I don't have evidence that coming in with more chemotherapy at that point, or Keytruda at that point, is going to do anything for anybody. And those medicines have side effects. And so we don't know what to do. But there's lots and lots of trials, guys, going on in women, whether it's ER positive breast cancer or triple negative breast cancer, when they finish, if they're high risk, when they finish, to get serial monitoring of this tumor DNA to see if you can catch it early before you can find it on PET scan. I'll tell you, in general, there's a limitation. Even with this best tests that are out there right now, looking for 16 or 20, 30 mutations, it's not necessarily sensitive enough yet to be able to find it early, microscopic. So by the time they did a study in England, by the time they found the tumor DNA in the blood for the triple negative patients, they did the PET scan. Most of the patients had cancer that they could find on the PET scan. So, you know, it was too late to do curative therapy, because we don't have curative therapy in general. There's exceptions for metastasized breast cancer. So the sensitivity is not quite where we need it yet.
And that is all so fascinating, how they're getting so down to the microscopic, evidence there, and it's very, very fascinating. I got a question here from Kim Luss. She asks, what would or sorry, would someone at stage 1 triple negative breast cancer need Keytruda?
No, Keytruda had to be stage 2 or stage 3.
Yeah.
Now, having said that, that was in the Keynote 522. There's another trial done called the NeoPact trial. It was presented by Priyanka Sharma at San Antonio 2022, and they included some stage 1 breast cancer patients. I think they had to be they certainly had to be more than a centimeter, maybe more than 1.5 centimeters, so larger stage 1s, and they got 6 cycles of preoperative Keytruda, not with the 4 chemo drugs that go along with Keynote 522, which is Taxol Carbo followed by AC, but it was actually 2 chemo drugs, Taxotere and carboplatin. So that trial did enroll some patients with stage 1. So sometimes, this is a gray zone. When a woman has a mammogram ultrasound and the ultrasound shows 1.5, 1.8 centimeters of triple negative breast cancer, lymph nodes look clear. If you get an MRI, for example, the MRI is going to probably show it to be closer to 2 centimeters, maybe a little bit bigger. After biopsy, you do an examination in the clinic, and because there's been some bruising in the mass, it's bigger. It might feel 2.5, 3 centimeters because it's been biopsied. So personally, I tend to give it the benefit of the doubt, meaning I'll lean towards adding the Keytruda to the preoperative chemotherapy if that woman is kind of like borderline, if you will, between stage 1 and stage 2, but certainly not for a small stage 1, like, under a centimeter, absolutely not. I do give chemo there. Under 1.5, not usually, because Keytruda, unfortunately, can cause death. There are 2 women that died from 3 women who died from Keytruda in the Keynote 522. One died of brain inflammation, another one died of pneumonitis, lung inflammation, and another one died of really low cortisol levels because her adrenal glands weren't working anymore after and she went into surgery, and she died in surgery because she had no cortisol. And so you got to be careful with Keytruda. It's not scot-free. It can cause long-term suppression of the adrenal gland. It's permanent. You have to take cortisone all your life. Super duper 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 rarely it can cause diabetes. You're on insulin for the rest of your life. So we don't give it to the lowest risk individuals, just women with
Right.
stage 2 or larger stage 1s.
You have to just kind of weigh the benefit versus risk in those scenarios, especially when it comes to stage 1. I got a question here from Paisley. She wants to know, does your PDL1 marker have to be positive for Keytruda to be effective?
Not for early breast cancer, not for stage 2, 3 disease. Keytruda works regardless of whether PD-L1's positive or negative. So we don't even have to look for it. If a woman has stage 2 or 3 TNBC, don't bother looking for it, because we're going to treat her with Keytruda anyway, provided she doesn't have a serious autoimmune disorder, which would mean we couldn't give her Keytruda because it will wake up. Like if she's got bad Crohn's disease or ulcerative colitis or something serious, we don't use Keytruda because it will wake up autoimmune disease. If a woman has metastasized stage 4 triple negative breast cancer, Keytruda only works if the PD-L1 is positive. So there we do have to look for it.
Yeah, I have a really interesting question here. I think that will be a quick answer for you. It's from Courtney. She says, does breast cancer pass gender to opposite gender? My dad had the BRCA gene, and then I had it too. Does it always go male to female when it's passed down? My brother isn't BRCA.
No, it's completely a flip of the coin.
Wow,
So
interesting.
your dad, your brother had a 50-50 chance of getting it, and you had a 50-50 chance of getting it. Your dad had a 50-50 chance, each of his siblings, your dad and each of his siblings had a 50-50 chance of getting it from whoever he got it from, his mom or his dad. No, it's a complete 50-50 coin toss. Has nothing to do with segregating with gender.
Yeah, gender or anything like that. Kim has a question. She says, what are the chances of stage 1 TNBC patient developing a different form of breast cancer after having radiation and chemotherapy?
Not very high, unless a woman has a family history or has inherited a genetic mutation. So if somebody got just, out of the clear blue sky, accidental, fluky, for no reason, triple negative breast cancer, and there's no family history or you're very minimal, and there's no genetic mutation, the risk of getting another cancer of any variety is low. It's probably on the order of 0.3% per year. So over the next 30 years, that might be a 9% risk, or so maybe 0.3 to 0.4%. So maybe no more than a 10%. All of us ladies walking around who have no family history, no gene we've inherited, we all have a 10% risk. All of us.
Yeah.
So the woman has about the same risk.
Yeah. So the thing that you mentioned that would make them maybe for higher risk would be a family history, or if they were BRCA positive or had a gene.
One of the other genes. Yeah.
Got it. Okay. This, I'm going to try to say these words. Paisley asks, if you already had Lynparza, can you do Niraparib? Does that sound right?
Niraparib.
Yeah.
No. It's because it wouldn't help, because we really think that the year of Lynparza is the best way to take your PARP inhibitor, and it's a one and done. It's the job is done after a year. You've got the max benefit. So the addition of the Niraparib afterwards would not be beneficial. And patients are not eligible for the ZEST trial who have had Lynparza for that reason.
Gotcha. I'm in a group, a breast cancer survivor group, and one of the things that I see come up a lot, people will ask, why do you think you got breast cancer? And then everyone will throw their answer. And I was surprised, just kind of watching, that the most common response was they felt they got breast cancer from stress. Can you get breast cancer from stress?
That's a really, really good question. And I would say two things to that. First, not that we really have a high level of evidence for, okay? So as you can imagine, that's very difficult to study, because stress is difficult to measure, because it can be episodic, it can be long-standing. And, when are we most vulnerable to developing breast cancer from stress? So this is very difficult. So not that we have high level of evidence for. However, in animal models, and Duke has done a lot of this work in animal models, if they stimulate stress hormones or stimulate stress receptors in animals, you can increase the risk of breast cancer, in the setting of other toxins and other things, maybe not by itself. There's been some interesting, and these are what we call hypothesis generating, not definitive, but like there've been work showing that women with triple negative breast cancer, I think it was TNBC, it may have been ER positive as well, who took a beta blocker for blood pressure, propranolol, metoprolol, one of these beta blockers that block the stress receptors, could have a decreased risk of breast cancer recurrence, or a decreased risk of getting it in the first place. But these are hypothesis generating. Now, triple negative breast cancer is one of those cancers where the immune system can play a very, very important role in curing triple negative breast cancer. In fact, I believe that's how TNBC is cured, by the immune system. And, there's a doc who I respect quite a lot named Laish Puzdai. He is in charge of breast cancer at Yale. And there's a lot of African-American TNBC at Yale, and, across around the country as well. And Laios has been studying the immune milieu of triple negatives across all ethnicities for a long time, and particular interest in African-American TNBC. And I know Laios feels that, for example, why are premenopausal women who are African-American, why do they have an increased risk of TNBC? Could it be for some communities, and that, we know about the social determinants of health. And the question is, if women are living under more stress, you know, and they're African-American premenopausal or African-American period or anybody, does that increase their risk? You know, I think Dr. Purjdai feels that stress may play a role in just incapacitating that immune system for a period of time. So, you know, there's some clues out there about it, but nothing really that I would say is definitive.
Yeah, that's a good answer. It could play a role in it, but definitely not all by itself, it sounds like.
Right, right.
I'm going to ask you one more question, and then we'll wrap it up, where you can just give everybody your heads up on what the best way to prevent recurrence is. So the final question from Kim Lusk here: what are your thoughts regarding dronabinol? Am I getting that right?
Dronabinol.
That's it.
Dronabinol.
Yes.
Dronabinol is good stuff for kind of difficult to control nausea. And the other one that's really good, so if people are getting chemotherapy or any of our medications that can increase the risk of nausea, I'll mention Enhertu, which is an antibody protein hooked up to a very powerful chemo drug that's used for metastasized triple-negative breast cancer that has a low level of expression of HER2, just a little whiff of HER2. So not HER2 positive, but triple-negative or ER positive disease has a little bit of HER2, and a small minority of women can get kind of chronic bad nausea that's hard to manage. And olanzapine, 2.5 milligrams at bedtime, really, really, really helps for gals that are struggling, whether it be with Enhertu or chemotherapy or whatever it is. Olanzapine, 2.5 milligrams at bedtime, helps a great deal with this, and it spills over into the day. So I put dronabinol in that same category. I don't use it very much. I use it when I need to use it for women who are struggling with nausea. The other medications are not working. The other place we use it sometimes is for appetite, where women are just losing weight. Some, you know, people lose their appetite all the time with chemo, but then it comes back, you know, before their next treatment, and they gain the weight back. But some gals lose, they just lose it, and it's becoming dangerous. And dronabinol can help with appetite as well.
Awesome feedback. Thanks for the questions, Kim, Paisley, Courtney, Mandy, everybody. Thank you so much for your questions. And the last thing we have is just every time we have you on, and also in case something has changed, but please let everybody know what they can do to prevent recurrence. What things that they can do.
So I think, of course, going to the mat, going all out with all of the proven therapies, okay? You know, getting surgery, getting good surgery, and getting radiation if necessary. You know, getting the systemic, that means the body therapy that's available, you know, and availing yourself, you know, if you have cancer still in the breast and lymph nodes after preoperative therapy, taking that 6 months of the Xeloda chemo pill, or taking that year of Lynparza. So go into the mat to get all the proven therapies. Of course, there's clinical trials going on now too for women who have cancer left after preoperative therapy. You know, we want to do better than Xeloda. And so there's trials going on looking at Xeloda, get Xeloda along with the Keytruda to finish up the year of Keytruda versus one of these newer drugs like Trodelvy, which is an antibody drug conjugate. It's an antibody protein hooked up to a very powerful chemo drug. It's already approved for triple negative for metastatic disease. And there's a competitor of Trodelvy called datopotamab. It's not FDA approved yet. It's by AstraZeneca, datopotamab. So there's these trials going on to make the next leap into the next advance to prevent recurrence. Now, other than that, what else can women do? So women can, we know that alcohol can increase the risk of breast cancer recurrence more than 1 drink a day. 1 drink or more a day. So I think it's safe to drink, if you drink at all, I think it's safe to drink 3, 4, 5 a week, but not 2 a day. It's too much. It increases the risk of recurrence. That's pretty clear. The Harvard Nurses Health Study, published by Michelle Holmes, I think it was, 20 years ago now, showed that these, tens of thousands of nurses around the country who had breast cancer. They were breast cancer survivors who had moderate paced walking 3 hours a week, reduced their risk of dying of breast cancer by 50%. And I don't even know if we even used the words TNBC 20 years ago. TNBC was still pretty new. I don't think they did subtype analysis, but I know it's going to work for TNBC because TNBC, like all breast cancers, can be woken up and activated by, substantial weight gain, because substantial weight gain, that's the other thing we can do, is try to not gain weight. And by that, I mean 10% or more body weight. We know that 10% or more body weight after a diagnosis of breast cancer can increase the risk of recurrence because of all the hormones from the adipose tissue, leptin, inflammation, insulin, lots of things can increase the risk of recurrence. Now, what we don't know is whether a 10% body weight loss sustained in women who are overweight or obese will improve the cure rate. There's trials going on looking at that. But I would say this, if women want to do that, if they're overweight or obese and they want to do that, the key here is it has to be sustained. Because if I start at 200, I get down to 160, and then I gain more than 10%, which is about 18 more pounds, I'm still less than I started with, but I've gained that 10% or more, you put yourself at risk. So avoiding 10% or more body weight loss, walking 3 hours a week or some moderate paced activity, and avoiding substantial alcohol intake are the three proven strategies to reduce the risk of recurrence.
If you're somebody, this is just me talking now, but if you're somebody who's 130, let's say, or 120, and you gain 10% body weight, is it still the same concern as it would be for someone who was considered overweight?
Good question. If somebody's 120 and they gain 20 pounds, that it's possible that could, I don't know, April, in the trials where they showed that 10% or more body weight gain, I have to go back and look at if somebody who's already starting with a normal BMI, does that still apply? But it might, because that's still a substantial change. If we go from 120 to 140, but 15 pounds from 120 to 135, probably just minimal, but it might be a small amount of risk.
Well, you're just keeping me in shape. That's all you're doing. So thanks for saying it. Well, cool.
Keep at it, honey. Keep at it.
I know. I have to.
I know,
I
God
have
bless.
to.
I know you're okay. So that's
Well,
good.
thank you. Thank you. Yeah. I mean, I think we all need that encouragement to stay on top of our health, both mental and physical. And I think that you've brought that point up in various ways for us all to continue to do that. And I just want to thank you again, Dr. O. You always stay over, and I'm sorry to keep you so long tonight. I really appreciate you staying. Yeah, I really appreciate it. The best part of the show is being able to really hit you up with a lot of these questions, and all the ladies who joined this evening had questions, and I know they're very grateful for you, and we're just so grateful to partner with you. And I can't wait to see you soon when we get to make our annual donation to your research and trials that you guys are doing over there, Texas Oncology, Baylor.
Thank you.
Yeah, can't wait to do that. And just thank you so much for staying late. I love you, and it was so good to see you.
Good to see you too, April. Thank you, everybody. And thanks for all the fundraising and contributions people are making. Really appreciate it. We got to keep the fight going. That's for sure. Take care. Good night, everybody. Thanks,
Thank
April.
you so much.
Bye-bye.
Take care, girl.
Bye-bye.
Bye.
Thank you. Bye-bye.
All right, everybody. That was Dr. Joyce O'Shaughnessy. We're so fortunate to have her join each year. Wow, what cool information. It's great because I know